My name is Michael Battelle. I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. Today on our FLA Fireside Chat, we have two very special guests from Evido Health, Taus Holtug, CEO and co-founder, and Dr. Katrine Prier, Lindvig, CMO and co-founder. A lot of us publicly share pretty much every day the risks and impacts of liver disease, and we spend a lot of time highlighting the need for early intervention. We invited you both to chat with us on FLA to talk about the innovative work your organization is already doing to help identify patients who have fatty liver disease earlier in their journey. You recently published a white paper, How to End the Global Liver Pandemic, and it was really appreciated by so many healthcare professionals and patients. What does Evido Health do, and how does your program work?
Yeah, no, thank you very much, Mike, for having us here with you today. It's we've been looking forward to talk to you about this. Yeah, my name is Katrina, and I'm a medical doctor within hepatology, also a clinical researcher. I have conducted a PhD thesis within early detection of fatty liver disease in primary care. So that is my main focus. Also, I'm a co-founder of Evido. And Evido is a medtech startup that focuses on early detection of fatty liver disease. Evido is founded on a decade of clinical research, lots of data and scientific publications. Evido is founded by Taus and I, but also my two dear colleagues, Alexander Krag and Maja Thiele, who are both professors in hepatology from Odense University Hospital here in Denmark. And Alexander and Maja and myself, we have seen the patients, firsthand, and we have had the urge to do something about this healthcare challenge for quite some years now. And that's, it's simply because that we have seen the patients when they come in way too late. And the tricky thing here about fatty liver disease is that 3 out of 4 patients are diagnosed when they are in the end stage of fatty liver disease, being cirrhosis with complications, also called decompensated liver cirrhosis. And at that point, there are not really much to do for these patients. We can ease their symptoms and so on and put out fires, you could say, but actually it's too late. So we really need to find these patients before they develop these severe complications to cirrhosis. And that's, in short, what we set out to do in Evido.
Yeah, and if I can just add to that, Mike, as well, and on top of what Katrina is already saying, because the idea is we want to ensure timely detection of people that are living with a hidden chronic liver disease. And what we find really mind-blowing is that these people, like with risk factors, they're in frequent contact with our healthcare systems. They go for different kind of checkups, they see the primary care clinicians, some of them also go to secondary care and so forth. And still, as Katrina mentions, 3 out of 4 is diagnosed when it's too late. And it's not that we don't see doctors being interested in liver health. Liver counts and liver function tests are some of the most sampled blood samples, both in primary care, but also secondary care. So it's kind of like mind-blowing. Why can't we detect these people in time? And that is the focus, as Katrina also mentions, primary care. We need to fill a gap here. We need to ensure that we could get high precision out to the GPs. We need to ensure that they can use the tools available, so we don't just talk about liver disease in small groups of experts. We need to in using a popular term, like democratizing specialized liver knowledge and ensure that we can support the patients out there, because GP's environment is chaotic. There's a lot of different patients, there's a lot of symptoms. So how do we make sure that they can actually support the patient when they see them? And that's kind of the cornerstones in Evido and what we're trying to solve here. Yeah.
So what do you both think is if you must have thought about this already, the key challenges that are happening already? Now there's new treatments that are on the horizon, and I imagine that is going to raise the criticality of action, let's say, from primary care. What do you think has been the challenge in trying to identify these patients earlier?
Yeah, I think that will create definitely, yeah, Katrina, I guess you have a good answer here as well. But I think that will definitely create more awareness around like how can we support these patients. But it like everything starts by detecting them, right? If we don't have any clue or suspicion that they have a disease, how should we treat them? So the first thing is actually providing tools, not in secondary care, but out where the patients are, because that's where we make a difference. We need to detect them before they progress into cirrhosis and before it's too late. So in our opinion, that is the key. There's of course different gaps in the patient pathway, but for us, that's the most important thing to kind of like turn this around.
Yeah, definitely. We need to, as hepatologists, we need to align with the GPs, because they are actually the ones seeing the patients within the time frame where we need to detect them. And one of the issues is that the liver doesn't have any nerve fibers, so you cannot feel your liver. You don't get any symptoms. You don't. I mean, if you have a heart attack, you will feel chest pain, right? But in this case, the liver is just a silent organ, trying its best until it can't do it anymore, and that's where the symptoms starts, and at that time, yeah, again, it's too late. So we need the GPs to be aware of this disease, and then we need to provide them with some actual precision tools that actually does what they expect the tool to do, being detecting the patients at the right time. And that's what one of the things we're trying to solve. Yeah.
Yeah, the as you both know too, the AASLD guidance statements came out just recently, and so they are looking to primary care as that first stop. FIB4, the liver assessments with scans, if possible, as the next stage.
Mm-hmm.
So
yeah, for sure.
I guess those are the tools you're talking about, giving primary care to
start. Yeah. So we're soon going to release more about our solution ourselves. We're not quite ready right now, but soon we'll get some more information. So a teaser right there. But looking at the solutions that are available today, a lot of them, a few of them is at least specialized for secondary care, and there's at least an economical side of bringing that out in primary care. We see FIB4 for sure, but we also see studies of that performing poorly in low prevalence cohorts. So we need some better tools than that. We need better tools that are not as costly as if you go to more advanced methods, because otherwise you won't have the opportunity to screen or find the cases in a big population. So when we talk about precision, we talk about precision in low prevalence cohorts. Even though it's a high prevalence, it's still a low prevalence compared to if you develop models for based on high prevalence cohorts. Another thing that is as part of as you mentioned, Mike, there's new guidelines, but we still need the educational element. So that's still very top down. I think this is the guidelines. We need to get it out to the GPs when they need it. We need to give the information when they need it. At least that's one of our big beliefs in ensuring user adoption. So they actually start using these tools and know how to deal with the patient. So it's not just a new test, a new value they get, but we need to support them with clinical guidelines. We need to support them what to do with the patients, how to support them. And we don't believe that the way to do is just through sending more material and educational stuff. It's about supporting the GP when they have the patient in front of them.
I have one quick question for you before we wrap up. So obviously we are all very liver centric, what message would you give to primary care physicians so that they might consider prioritizing the liver just a little bit to start with?
Oh, that's a good one. No, I mean, first of all, we need to actually making them aware that the way they use liver function tests today is what we would like to provide them with, actually. So instead of the normal liver function test that they use as a broad screening of how is this given patient's liver actually functioning, we would like to provide them with that test. I mean, so that they can keep using it the same way they do today, but with a tool that's actually working in the intended way. That we would like to provide the GPs with. Yeah.
That sense?
Yeah, I think Katrina says, and it's also coming back to one of the challenges, right? As mentioned, liver function tests are some of the most sample tests. So it's not that the GPs are not aware or not interested in the liver. They're just not aware that some of these tests are developed for hepatitis. And when looking for fatty liver disease, that's not the appropriate tool to use. So it's, yeah, as Katrina said, they changed the mindset. But there is the barrier of getting them better tools before we can actually change this whole challenge pathway for the patients.
Okay, that's great. Well, thank you both very much for the time that we spent together today. And I am definitely looking forward to progress and further discussions with both of you so we can share that.
Thank you so much, Mike.
Thank you very much.